Hey guys, welcome back to the channel. If you're new here, my name is Lukas. I'm a first year ophthalmology resident at the University Eye Clinic in Germany, and on this channel I produce videos about healthcare, productivity and lifestyle. The goal of this channel is to help you guys have a more productive, healthier and at the end happier life. If you like the content that I'm producing, please feel free to subscribe to my channel. I would be very happy about that. In case you have any question about a topic or anything that I'm talking about, please send me a message and I will come back to you. Today's video is another Life as an Ophthalmologist video. So I will talk about my experiences at work. The last couple of weeks I've been working a lot at night time, so this means I'm working from around like 7:30 p.m. until 7:30 a.m. the next morning. At this time I'm basically the only ophthalmologist at our university clinic and also the only ophthalmologist in the entire city. That means I'm responsible for every person with an eye problem. And that's around like 600,000 people, and with the suburbs maybe even some more. Sometimes when I'm lying in bed at work at night, I think about this and I feel like it's a huge responsibility for me. But yeah, it's a lot of fun and it's great. You learn a lot. And I've seen some really cool and interesting cases the last couple of weeks. I'm looking forward to share these cases now with you guys. The most common cases that I saw during my night shifts in the last couple of weeks were patients with acute conjunctivitis, corneal foreign bodies and corneal abrasions. In my last video I spoke a lot about emergencies in ophthalmology, and a few people asked me like, what are the most common cases of all the cases that you presented? So these kind of three emergencies are basically the most common ones, I would say, in ophthalmology. So besides that, I've seen a few cool and interesting cases last week. The first one I want to talk about, it was a case. I was called at 3 a.m. in the morning. The oral and maxillofacial surgeon called me and he said, basically there's a patient here and he has some acute vision loss. He got a surgery 1 or 2 days ago. He had a blowout fracture, so an orbital fracture, and now suddenly decreased vision. So I took a look and saw the patient. He had decreased vision. My colleague saw him before the surgery. The vision on the right eye was 0.63 and right now was reduced to 0.3. Besides that, he had also a really huge exophthalmos and acute chemosis and subconjunctival hemorrhage. The motility was decreased on that eye and also had an afferent pupil defect. And I thought this is really suspicious for a retrobulbar hemorrhage. I told the surgeon that it would be probably necessary to do a lateral cantotomy. And therefore the surgeon decided to do a computer tomography of the head, and they realized that it was a retrobulbar hemorrhage, and a few hours later the patient got the surgery. My colleague at work saw the patient 1 or 2 days later, I think. At this point the vision was increased again, and yeah, this was a case where the acute treatment really helped and saved the vision of this patient, because otherwise the pressure on the optic nerve could have caused really bad and irreversible damage. The next case I want to talk about is an older female patient with an acute closed globe injury. This woman used a bedsheet tensioner, and while this one was under tension, a metal part of that flew against her eye, and after that she was having an acute severe vision loss. When she arrived at our emergency department, I first spoke about her history. She told me that she was pseudophakic on both eyes. Besides that, she didn't have any surgery or any disease on both eyes. Vision was really good before that. Yeah, when I took a look at her eye, I could immediately see that there was a lot of blood in her anterior chamber and she had a high femur. The motility of the eyes were intact. Because of the blood, it wasn't possible to do a pupil or visual field examination. Also, a deeper insight in the eye was not possible. The conjunctiva was intact. There was no sign of an open globe injury, no ecchymosis or hemorrhage. The cornea also looked intact and the anterior chamber was deep. The intraocular pressure was around like 24. There was a lot of blood in the anterior chamber. Besides that, you could also see that there was a dislocation of the lens. Part of it was inside the anterior chamber. After that, I also did an ultrasound of the eye. This one showed no vitreous hemorrhage and no retinal tear or retinal detachment. The diagnosis in this case was a high femur and a lens dislocation. We prescribed topical steroids and some anti-glaucoma therapy. The next case I want to talk about, there was a younger Indian patient sent to our emergency department from another private eye clinic. They asked for further evaluation of the patient and diagnosed a high femur after an enclosed globe injury. When I first saw the patient, he told me that 2 days ago his young son touched or bat his eye with his fist, and after that he felt some pain and some decreased vision. Besides that, he told me that he has a glaucoma disease and got a trabeculectomy on this eye. Besides that, he did not have any disease or surgery on both eyes. Visual acuity was decreased on the eye. The intraocular pressure was normal, the motility was intact, and the pupillary examination did not show any pathologies. When I looked at the anterior segment, I could see that the bleb on this eye looked very infected and the conjunctiva was also injected. Besides that, the cornea was clear, the anterior chamber was deep, and there were a lot of cells and proteins inside the anterior chamber. However, it did not look like blood cells, it did not look like there was a high femur. And the patient also had a little hypopion. The deeper insight was not possible, so then I decided to do an ultrasound, and this one also did not show any vitreous haze or retinal tear or detachment. This case was actually a blebitis, so this is an infection of the bleb. It's a very serious, dangerous infection of the eye that can also lead to an endophthalmitis. As a treatment, we prescribed the patient local antibiotics and also systemic antibiotics. Besides that, also topical steroids and anti-glaucomatous eye drops. The next couple of days, the inflammation really decreased more and more. And yeah, after like a week or so, the patient was already able to leave the hospital again. The final case I want to talk about was a young female Indian patient. She was sent to me from the neurologist and she had a confirmed optic neuritis, and the neurologist asked for further evaluation of this case, thinking that she had a new acute episode of this disease. She told me that the symptoms she had were decreased vision, temporal visual field defects on the left eye, flashlights for like 2 days, and headache, and also pain with eye movements. All the symptoms started around like 2 weeks ago. And besides that, she told me she had no other eye diseases and no surgery on the eyes. When I did an examination of the eyes, this showed that the visual acuity on the left eye was reduced to 0.5. The intraocular pressure was normal, the motility of the eyes was normal. She had some pain with eye movements. The pupil examination did not show any pathologies. There was no relative afferent pupillar defect. She also did not have decreased color vision. And the anterior segment examination showed no pathologies. When I did a fundoscopy and an macular OCT, I was able to see a serous retinal detachment, which was from the macular to till the optic nerve. Besides that, was no other pathology seen. I then spoke to my attending, and she basically expected that this would be a Vogt-Koyanagi-Harada Syndrome. So what we did then, we took some blood and did a check for tuberculosis, Lewis and sarcoidosis, and also did a check of the kidney and the liver function. Furthermore, we prescribed high-dose methylprednisolone for 3 days, and also plan to do another macular OCT the next day to see if the serous retinal detachment has already decreased. The further treatment would then be to change the methylprednisolone from IV to oral and slowly reduce it from time to time, and then do further checkups the next couple of months, and yeah, probably stop the prednisolone intake after like 3 to 6 months.